Good morning, and welcome to the spring seminar series for the Florida Department of Health Grand Rounds. February is Prenatal Infection Awareness Month, and today we welcome James Mathias from the Florida Department of Health. A few things to know before we get started today. All of the phone lines are muted. Please enter your questions into the question box on your control panel. We will have time for Q&A at the end of the presentation. For your convenience, the slides from today's presentation can be downloaded. Please click on the PDF file located under the Handouts tab on the control panel of your screen. For those of you that would like to receive nursing continuing education credit, please fill out the survey that will automatically pop up when the webinar concludes. Be sure to enter your correct license number. Today we have Dr. Emma Spencer, Bureau Chief of Communicable Diseases, to introduce our speaker. Good morning, Emma.
Good morning. Thank you, Robin. Good morning, everyone. As stated, I'm Bureau Chief of Communicable Diseases here at the department. Under that bureau, we are responsible for all surveillance, prevention, care, and treatment operations related to HIV, STD, viral hepatitis, and TB. This morning, I have the great pleasure of introducing the next Grand Rounds presenter. I've worked with Jim Mathias over the past 6 years, who is currently a field epidemiologist and member of the Global Rapid Response Team for the Division of STD Prevention at the Centers for Disease Control and Prevention, and he is currently assigned to the Florida Department of Health. His primary focus of study involves applied public health practices surrounding maternal and congenital syphilis, STD partner services, and STD surveillance and informatics. Jim has led or co-authored many peer-reviewed articles on these topics and actually recently received a CDC Honor Award for his team's work, of which we're very proud of him, on congenital syphilis program delivery. Prior to his role at CDC, Jim is an epidemiologist here at the department and even started his public health career as a CDC CSTE Applied Epidemiology Fellow. Jim's work in Florida is extremely important as he helps us navigate the issues surrounding increases in congenital and female maternal syphilis. Today's presentation will focus on that very topic, and we will hopefully engage you to think about the challenges we are seeing and to start conversations at the local level on how we can move the needle to reduce syphilis in the state. Thank you, and I'll pass it to Jim.
Thank you, Dr. Spencer. And I look forward to talking with all of you about the state of maternal and congenital syphilis in Florida in 2021. For those of you who understand why we're having this conversation today, I'm glad to have you all. And for those that are a little bit less familiar with maternal and congenital syphilis, you may be wondering a little bit why we're talking about syphilis. You may be wondering, syphilis, does it still exist? You know, we have these signs from the 1930s talking about protecting ourselves and stamping out syphilis, or syphilis being as old as the dinosaurs. And when we talk about the history of syphilis, our first recorded outbreak of syphilis was all the way back in 1494, well before the famous John Snow pump handle outbreak. And really the term syphilis itself is actually from an Italian work in 1530 as a character from the play Syphilis Civ Morbus Gallicus. And if my Italian is a little bit off, I'm sorry, that actually translates to the French disease. And so the French, the Spanish, and the people from the United Kingdom had all used the term the French disease. Not to be outdone, the French actually called it the Neapolitan disease or the Naples disease. And so of course the German decided to call it the Polish disease. Pretty much anywhere you go, it's a disease of the other. So syphilis has been around for hundreds of years. And one interesting fact is when we talk about the giant powdered wigs that was around in Europe in the 16, 17, and late 1700s called perukes, one of the reasons for these giant powdered wigs was to help hide their syphilis infections. One was to help hide some of the syphilitic sores that may be there, but also the syphilitic hair loss that comes along with some of the signs and symptoms of syphilis. So that's one of your interesting facts related to syphilis that you can share with your friends. So again, syphilis may seem like a disease of the past and we don't talk about very much recently. As a matter of fact, there was a plan to eliminate syphilis because following the use of penicillin for syphilis in 1943, syphilis rates plummeted. And in 1993, we saw a historic low of only 6,993 . cases in the entire country. So we only saw 7,000 cases in the entire country in 1999. So another fact here, when we talk about syphilis, it's actually one of the longest reportable surveillance diseases that in the United States. We've been collecting surveillance data since World War II in 1941, and it's become a nationally notifiable disease since 1944. And realistically, we started using penicillin to cure syphilis since the early 1940s. And that's one of the reasons why we have surveillance data around this, is to help us understand the effects and trends on syphilis. So as you can see, realistically, in the early 1940s, around World War II, we actually had upwards of 500,000, almost 600,000 cases of reported syphilis back in the 1940s. And we could see the advent and use of penicillin caused a rapid decline in the amount of syphilis that was observed in the United States. And that was declining all the way through the 1980s until we saw an increase again in what we call the area where we had an increase in the late 80s and early 90s of surrounding crack and cocaine use and other populations prior to the HIV epidemic really spreading and causing another decline in the late 90s, leading to, as I said, the lowest observed number of syphilis cases in 1999. And we had the syphilis elimination effort to try to stamp out syphilis for good in the United States, similar to what we did with the polio and smallpox eradication efforts. And unlike those efforts towards polio and smallpox, we are starting to see a massive resurgence in syphilis again, similar to what was observed in the late 80s and early 90s here in the last decade or so. So here in this presentation, we hope to have a syphilis overview to describe what's currently going on with syphilis across the nation, but also explain the epidemiology of maternal and congenital syphilis in Florida. And then finally, we want to take a quick deep dive about the evaluation of our demographics and screening practices on congenital syphilis prevention within Florida. And finally, talk about how these impacts of maternal congenital syphilis changes have had on our infants, and have a brief discussion about what this all means going forward. And before we get started, throughout this presentation, we'll use the term CS on the slides, and that's to designate congenital syphilis. So a brief syphilis overview to help get us all oriented. So what is syphilis? Syphilis is a bacterial infection caused by a spirochete called Treponema pallidum. It's transmitted primarily through sexual activity, but it can be transmitted vertically from mother to child during pregnancy. It's characterized by 4 stages of adult disease progression. We talk about primary syphilis, secondary syphilis, early non-primary, non-secondary syphilis, which is a disease of asymptomatic infection. And then there's late or unknown duration syphilis, which is a further asymptomatic infection that's actually not being able to be characterized further along the spectrum. Additionally, we can have neurological, ocular, or otic symptoms that can present during any of these stages that aren't characterized within any of these additional signs or symptoms of syphilis. So how do we diagnose syphilis clinically? Well, to know syphilis is to know medicine is often one of the phrases. And syphilis is a great imitator because it appears like many other diseases. Primary syphilis is often diagnosed with a painless chancre, seen here on the right. And the problem with the painless chancres is that it'll also heal and resolve on its own. It'll also disappear. And it also, in many cases, looks like other lesions that may appear in the genital area. Or it may also appear at the site of where the infection may occur. So it may not necessarily always be in the genital area, but again, where the site of exposure occurred. Once the disease resolves in the primary area, the pathogen will spread throughout the body. As it spreads throughout the body, secondary syphilis starts to appear. This spreading throughout the body is called secondary syphilis, and it comes with signs and symptoms like hair loss. It can also come with body rash, including particularly when we talk about the hands and feet. It's kind with the term palmar-plantar rash, as you can see in the picture here on the right. It's a sign of the rash on the hands. It can also appear on the soles of the feet, but it also can be a generalized rash across the trunk of the body, the torso, and other areas. So sometimes when it doesn't appear with the classic signs on your hand and your feet, but have a generalized rash, again, it's hard to differentiate from other rashes that can be on a person's body. Finally, larger lesions can appear, and we call those condyloma lata, which are similar to the chancres but are spread throughout the body and can contain the spirochetes themselves. And finally, other signs and symptoms as this is progressing throughout the body may resemble most other illnesses like fever, sore throat, fatigue, and other common cold-like symptoms. Then we often hit a period of dormancy in terms of symptomatic individuals after secondary syphilis, and we call this latent syphilis. And this is the two stages we talked about earlier, which was early non-primary, non-secondary syphilis, which is where we can use other epidemiological evidence to determine infection in the last year. Or we talk about late or unknown duration, which is parts where we either can't determine or it's been determined the infection occurred more than a year later. Tertiary syphilis is often syphilis that has now been inside the body for much longer than primary or secondary syphilis, which can occur within weeks of the initial infection. Syphilis itself can be fatal, although it is not often as fatal as it was years before and prior to penicillin. And this is caused from dissemination to the organs, including the brain, heart, liver, or other organs. This example on the picture on the right is a gumma lesion here on someone's nose, and you can see the type of sores and open wounds it can leave on the skin. But again, we can also talk about neuroocular and otic syphilis that can present at any stage of syphilis. Some examples of neurosyphilis are headaches, migraines, disorientation, problems with memory loss. Ocular syphilis can lead to floaters, blindness, redness in the eyes. Otic syphilis can ringing in the ears. These are all things caused by the pathogen leading to destruction of different aspects of the neurological, ocular, and otic systems. So how do we diagnose syphilis by the laboratory? And typically when we talk about diagnosing syphilis, it's based on a two-test system that indirectly tests for this pathogen. And we talk about a treponemal antibody-based test, which you are positive for life. And this is a qualitative test. So really we're testing for antibodies to treponemal pathogens. And then we also talk about non-treponemal syphilis tests, which will vary by person, their stage of disease, and treatment. And this is a quantitative test. So depending on treatment and things like that, this can be something that can be used to determine if someone has been reinfected and how treatment has worked to determine if someone has had an appropriate response to therapy. The key point here is that neither of these tests directly detect the organism. So in some cases, this can lead to false positive tests for people who are not actually infected with syphilis. However, occasionally we do have direct testing methodologies. We do have PCR, dark field microscopy, and other special stains for spirochetes. And you're asking, if we have these types of tests, why aren't they used more frequently? Well, PCR and dark fields are really only able to be used in primary syphilis, which is when you're able to swab the lesions themselves to get the spirochetes to be tested. And primary lesions are not readily easily identifiable in most individuals, and most individuals are not as willing to be tested for these sensitive areas in these types of testing compared to having a simple blood draw or screening applications. In some cases, lesions can be quite hard to find, especially on female populations. And the other special stains we talk about for spirochetes are often done in biopsies or in autopsies for other chances to be able to do these immunohistochemistry stains. So that's why we often do not see very many PCRs or dark field microscopy stains, even though they were more common, particularly for these lesions in primary diagnosis in the past. So now we talk a little bit about the epidemiology of syphilis. So when we used to talk in the 1990s, is when we were talking about the epidemiology of the previous epidemic, there was a large number of cases in both males and females, and there was a large number of congenital syphilis cases per 100,000 population in both the 1990s. And the male to female ratio was very small. It was about 4. As time progressed, the male to female ratio rapidly began to grow, and the male ratio and the male case numbers both began to grow throughout the 2000s. However, somewhere around 2013 or 2014, we began to see the female rate also start to increase across the United States, and we started to see the male to female rate ratio also start to decrease, even though the male rate was continuing to decrease in syphilis nationally. So why are we talking about syphilis in women when the male rate is so much higher? Well, the risk of vertical transmission of syphilis from mother to child during pregnancy is what makes syphilis in women different than syphilis in men. And so what is congenital syphilis? This is the potentially fatal infection passed from mother to child during pregnancy. And when we talk about congenital syphilis, as we see from some of the pictures at the right, we're talking about an infection that can lead up to 40% that may result in miscarriage, stillbirth, or infant death. Plus, the non-fatal infection can lead to some of the severe sequelae that you can see on the right, including bone deformations that you can see in the x-rays on the right, hepatosplenomegaly, severe anemia, neurological issues that also include blindness, deafness, and more, including rashes, snuffles, and other severe consequences that can lead to the infant being born with congenital syphilis. Now, before we move further into actually what the epidemiology is here, I want to have a brief discussion on what the surveillance case definitions are versus the clinical and laboratory discussions, because we will be talking about surveillance case definitions for a lot of this as we work with the Department of Health. For adult syphilis, an initial diagnosis usually involves serological evidence of a syphilis infection, and then we also stage the infections based on symptoms and/or epidemiological criteria. So the serological evidence, again, usually consists of both the treponemal and non-treponemal test, unless we have the direct detection through PCR or dark field microscopy. And when we talk about reinfections or subsequent diagnosis, we use serological evidence of a new infection, usually via change in a non-treponemal titer. And we have direct evidence of symptoms, syphilis symptomology consistent with a new infection. Again, like a primary chancre or a syphilitic rash in secondary syphilis. However, when we discuss congenital syphilis, there are basically only 3 ways to meet the congenital syphilis case definition. And these are, again, a little bit different than how they are in the Red Book or in the STI treatment guidelines for how it is for a surveillance case definition. And that is basically the 3 ways to meet the CDC and state case definition is that the mother is not adequately treated for the stage of disease, consistent with the STI treatment guidelines, greater than 30 days prior to delivery. That will lead to an infant meeting the case definition. Or the infant has a reactive non-treponemal test and has signs and symptoms consistent with the congenital syphilis, regardless of mother's treatment status. Or the infant is a stillbirth after 20 weeks gestation to a mother who had syphilis during her pregnancy. So now we'll talk about maternal and congenital syphilis epidemiology in Florida. So now when we talk about the issue of congenital syphilis increasing, we talk about congenital syphilis increasing not just in Florida, but nationally. In the decade starting in 2009 to 2019, we observed nearly a 600% increase in congenital syphilis in Florida. We increased from 21 cases in 2009 to a reported 146 cases in 2019. Now, we're using the report year 2019 because nationally, that is the most recent complete reporting year. Likewise, nationally, we have seen a 334% increase in congenital syphilis nationally during the same time frame, from 431 reported cases nationally in 2009 to 1,870 reported congenital syphilis cases across the nation. I will say, though, however, in Florida, as we have reported completed data for 2020, Florida did report 154 congenital syphilis cases in 2020. And a lot of this is coming from the fact that we also are seeing an increase in primary and secondary syphilis, which again is our 2 infectious stages of syphilis or symptomatic stages of syphilis among women, increasing both again in Florida and nationally. We saw a 218% increase from 2009 to 2019. And although the other graph previously showed a much more straight increase, when I mentioned we saw the increase starting around 2013 and 2014, you can see each year from 2014 on, we have seen an increase in female primary and secondary syphilis in Florida. And that has resulted in a 218% increase since 2009, from 147 reported cases of primary and secondary syphilis in women to 468 reported cases. And nationally, they have seen a very similar increase of 191% over the same time period, from just over 2,000 cases to almost 6,500 cases of primary, secondary syphilis cases amongst women. And again, in 2020, we saw another increase in primary and secondary syphilis amongst our women, with over 500 cases now being reported in Florida. Now, historically, we often saw congenital syphilis being reported in our larger metro areas. And if we look at 2018, we had 22 counties, which was a lot, reporting at least one case of congenital syphilis, and 6 counties reporting 5 or more congenital syphilis cases. Now, if we look at 2020, 33 counties reported at least 1 or more congenital syphilis cases, or half of the counties in the state of Florida. And we have 9 or more counties reporting 5 or more cases of congenital syphilis in the state of Florida. So not only are we reporting more cases of congenital syphilis, it continues to expand throughout the state of Florida, and there are more counties reporting a larger number of congenital syphilis cases. So in many areas, they used to, if you thought that this was a problem of other jurisdictions, in many ways it is becoming a problem of every jurisdiction and area within Florida. Now, for a brief discussion, I want to talk about some of the disparities of congenital syphilis by race and ethnicity in 2020. So if we look at the top picture here, we're talking about congenital syphilis cases born to Black women, Black females. 5 and 10 congenital syphilis cases were born to Black women. That means 1 and 2, or as I said, 5 and 10 congenital syphilis cases were born to Black women. If we work further upstream, it's not just congenital syphilis cases where the disparity exists. 5 and 10 pregnant women diagnosed with syphilis were also to Black females. And again, if we work further upstream, over 4 and 10 women, nearly 5 and 10 women with syphilis were among Black females. So we just want to highlight here that the disparity works continually upstream and across all spectrums in congenital syphilis prevention, where there is a disparate effect on Black females and Black children, or children born to Black females, where congenital syphilis has a disproportionate effect on this community. And now when we like to talk about a little bit about risks related to drug use amongst pregnant women with syphilis, because we often hear around a national level, specifically out west, that the drug use and methamphetamine use has increased dramatically. We have not seen the same increase in drug use amongst our pregnant women with syphilis in Florida over the same time frame from 2013 to 2019, although we have seen a slight increase in meth use from 1% of our pregnant women to 4% of our pregnant women. And the reason we have used methamphetamine, crack, and heroin here on this slide is those are the drug uses as those are reported in a national MMWR report. Opioids are not captured as a part of our standard syphilis surveillance. This data, as I said, goes back all the way to the early 1990s and beyond. And other drugs that we do capture are not included in this report, as these are the ones that were used in the national report for comparison purposes. But just to highlight here that even though that drug use is a risk for congenital syphilis and pregnant women with syphilis, a very high percentage of our women are not self-reporting drug use during their pregnancies, and it's not increasing dramatically over the last few years as observed nationally in other areas. So that leads us to what have we done for maternal and congenital syphilis programmatic evaluations in Florida over the last several years to combat the scourge of congenital syphilis. Well, in 2013 and 2014, we worked with Louisiana on a partnership to understand what were the causes of our cases. And so one of the primary causes we saw with 25% or a quarter of our cases is that they had no recorded syphilis test or a lack of prenatal care basically in nearly a quarter of our cases. So there was not a lot that could be done from an STD prevention program practice part or from a medical provider's practice part when there was a lack of prenatal care and women showing up for delivery in a quarter of our cases. One of the challenges we did find, though, was that 35 or 23% of our cases were not rescreened after a negative early pregnancy syphilis test in the first or second trimester, when they could have been rescreened in their third trimester at 28 to 32 weeks of pregnancy. Additionally, another challenge we have is the third most common reason in 2013 and 2014 was that nearly 10% of our mothers had a 4-fold non-treponemal titer increase during their pregnancy and after treatment. Or basically a way of summarizing this is that they basically had signs or symptoms of a reinfection or treatment failure during their pregnancy, leading to a potential congenital syphilis infection that was identified by case definition. Again, this is a real challenge for prevention by STD programs when reinfections occurred during their pregnancy. The fourth reason, we found that mothers were treated less than 30 days prior to their delivery. And this could be because they were either tested late in the third trimester or that there were delays in programmatic delivery to this treatment for a multitude of reasons. And finally, the fifth reason is mothers had insufficient treatment for their late or unknown duration of syphilis. And for late or unknown duration of syphilis, it requires 3 doses, 7 days apart, for treatment to sufficiently be considered sufficient according to the STD treatment guidelines. And again, that's 8% of our women. The remaining 38 cases were for a multitude of causes that comprise 25% of the total population. But again, 75% of our cases could be broken down into those 5 main categories listed above. Furthermore, that helped us lead to establishing congenital syphilis review boards to further identify specific areas where we could improve practices across each of the areas. In 2019, 85 cases were reviewed by these congenital syphilis review boards. In 33 of those cases, we were able to determine 33 of those had clearly preventable or semi-preventable opportunities for improvement, where mothers were in care and there were missed opportunities to prevent a congenital syphilis case. In some of those cases, there were delays in treatment initiation, or there were missed opportunities for screening or testing in prenatal care, with or within their healthcare settings, or other opportunities where screening or testing could have occurred, or there was inappropriate treatment for stage or spacing in a treatment administration. But in 2019, we found that it became more challenging and that 61% or 52 of our cases had less clearly defined opportunities for intervention. Again, one of the main problems was a lack of prenatal care, where 43 were identified to have less than 30 days, were identified by screening less than 30 days prior to delivery. Reinfection was becoming identified by serology at delivery to continue to be a problem. The term birth tourism remained an issue. This is a term for pregnant women from other countries arriving prior to delivery just to deliver their baby in the United States, and therefore arriving with often less than 30 days prior to delivery, so the opportunity for intervention is less clearly defined. And on a few of these, there was an incomplete interview of mother or records obtained from prior pregnancies to be able to truly be able to have an opportunity to intervene over the course of their care. So then when we look about our partner services, which is one of the cornerstones of care for an STD prevention program, we looked at our partner services outcome for our early female syphilis cases, which again are the primary, secondary, and early non-primary syphilis cases in 2015 and 2016. So we interviewed 1,066 of our female syphilis cases. And so when we really start with that, we found out that 70% of them named at least one sex partner, which is good. The problem is that means we did not have disease intervention for at least 30% of our female syphilis patients off the start. And of those 70% though that did name one sex partner, we had 1,028 sex partners that we had an opportunity to intervene with. And we were able to bring 23% of those 1,028 to treatment on or after the index patient, which means that 237 were actually brought to treatment and identified as new infected syphilis partners from our 1,066 interviewed patients. Well, that means we were not able to identify the source infections for several hundred individuals. That does not necessarily mean that we did not have success, because in many ways we were able to preventatively treat 25% of our additional partners, and we're also able to test 14% of our other additional partners who tested negative. So we were able to provide some form of disease intervention or preventative treatment for an additional percentage of our partners, bringing our total to much higher for our disease intervention than just the 23% where we were able to bring actual treatment for newly identified cases. And then one of the other challenges that we've been looking at, or one of the goals of the CDC programs, was to identify pregnancy status in a timely way. As you can see, from 2013 through 2016, the pregnancy status that we had started to become more and more missing for our females of childbearing age. In 2013, it was 4.9%, but by 2016, it had reached 15.1%. So working with the Florida Department of Health and our development team, Dan George and others, and Craig Wilson and others, we worked to build an automated alert system within our STARS surveillance system to automate a weekly alert that goes out to field staff, reminding them of females of childbearing age that don't have a pregnancy status. And in early 2017, we used that to be able to bring down our missing pregnancy status for females with syphilis from 15 to 44, from 15% to 1.8%, and by 2018, 1.1%, despite the fact that we had increasing numbers of female syphilis aged 15 to 44 each year. And when we looked at that, we found that most of those with missing pregnancy status that were resolved, that had opened at the time of this implementation of our system, 95% of them were determined to not be pregnant, which is a good sign that the ones that had unknown pregnancy status at that time were truly not pregnant. But at the same point, we are able to then also have a more timely ascertainment of our pregnancy statuses going forward, which can allow for better disease intervention going within our program. But probably one of the other challenges that we've seen with our program, and one of the things why we continue to work hard to do congenital syphilis prevention within our STD program, is we've continued to see challenges within our case aversion or case prevention rate of congenital syphilis. And that's followed by that gray line that's going across these graphs. As you can see, the number of pregnant women and congenital syphilis cases seem to be increasing each year since 2013. The total stacked bar is the number of pregnant women with syphilis, and then the orange bar is the number of those that resulted in congenital syphilis. So the percentage of those that congenital syphilis cases prevented are those that are in basically the blue bar out of the total bar. And so as you can see, the higher percentage of the orange out of the total bar, that would mean that we are not preventing as many cases. And you can see as the gray line decreases, even though we peaked in 2014 with nearly 80% of our congenital syphilis cases prevented, we are continuing to have challenges in both congenital syphilis prevention and opportunities for us to look as to why, as we had our last major evaluation in 2013-14, to why we're looking at our percentage of congenital syphilis cases prevention decreasing successively with years to now closer to 67% of our cases being prevented in 2019. So that led us to our evaluation of our congenital changes in maternal and congenital syphilis over time from 2013 to 2019. And so as I said, our previous evaluation period was 2013 and 2014, and we looked at this with Louisiana. And at the time, we thought we were seeing a rapid increase in cases, both in our particularly in our congenital syphilis cases. But what we didn't know at that time is what was going to happen going forward in 2018 and 2019, both with our infectious female syphilis cases and our congenital syphilis cases. So now we wanted to look what has been leading to those changes and what had been missed in our original evaluation in this second time period. So since these facts, and so we wanted to look, is this simply an increase in pregnant women with syphilis? Because I said we've seen the increases in females with syphilis. Or has the population or prenatal practices of our pregnant women diagnosed with syphilis changed over the past 5 years? And is that what's contributing to our decline in preventing congenital syphilis cases as well? So in 2013 and 2014, we had 404 maternal syphilis cases, resulting in 83 congenital pregnancies. So the best way of putting this is that in those 2 years, we had 79% of our potential congenital syphilis cases prevented. In 2018 and 2019, we had 809 maternal syphilis cases. This is a 100% increase in women who are pregnant with syphilis in just a 5-year period. In 2018 and 2019, we had 258 congenital syphilis or congenital pregnancies. This is a 211% increase in a 5-year period. This also results in a decreased congenital syphilis case prevention to 68% of our potential congenital syphilis cases prevented. So we wanted to assess what attributable proportion was due to our changes in maternal population. So if we took our prevention of congenital syphilis cases in 2018-19 and put it at the rates of our 2013-2014 prevention rates, which was 79.4%, we would have expected 167 cases instead of 258 cases that was observed. So we can say that basically in excess 93 cases were due to a reduced efficiency in our congenital syphilis prevention. So roughly a minimum of 65% of our congenital syphilis cases can be explained by the rise in volume of our maternal syphilis cases. So what does that mean for the rest of our cases? And then what does that mean for our changing population, and why do we expect to see them? Was it a change in the women who were having syphilis? Was it a change in the location of where we were having syphilis? Was it a change in our screening practices? Was it a change in what's going on? So we decided to look at that a little bit further. So if we look at our demographics, and we expected to see some things be different. What was surprising to us is that we did not observe any changes by race or ethnicity. And what we saw was that it was exactly the same pretty much in 2013 and 2014, and is what we saw in 2018 and 2019. And the age of our women didn't really change. The mean age was 27 in 2013 and 2014, and 2018 and 2019. What we did see is that pretty much the only difference by demographic was that it was slightly more US state born. And we use the term US state born because in many ways, the idea here is that this is a proxy for some of the birth tourism that was actually a large proportion of our cases in the early 2010s has actually started to decrease in 2018 and 2019, which is more suggestive of the infection being acquired locally than what it was prior to before. But what we did see is some changes in our maternal syphilis risks and infection factors. We'd started to see an increase in drug use from about 6% of our mothers reporting the infections in 2013-14 to around 10% of our mothers reporting drug use in 2018 and 2019. And it is a little bit higher in those that resulted in congenital syphilis infections, both in 2013 and 14 and 2018 and 2019. We also saw a change in our non-treponema titers being reported in our cases. We saw less low titer syphilis being reported and more medium titer syphilis being reported, which again is more indicative of more recent and active infections, whereas low titer is more indicative of late or unknown duration infection, which again is not surprising that we then see more P&S syphilis being diagnosed in 2018 and 2019. And again, when we combine our stage and titer, we are starting to see, again, an increase in early or high titer or late unknown duration. So really what that change is suggesting when we combine these all together is what we're trying to say here is that what we're seeing is more acute or incident infections than what we were seeing in 2013 and 2014. And 50% was actually quite high in 2013 and 14 and was surprising when we did that analysis in the literature at that point. And now we've upped that to 62%. So instead of 1 in 2, we're now 3 out of 5 of our infections could be classified as being infected within the past year. So when we then looked at our screening charts, and there's a lot of information here, and I'm not going to cover all of this on this slide, but what I want to just point out here is that when we looked at all the different opportunities for screening, and this is what was done in 2013 and 2014, you can see where each of the women followed in a flow chart, and you can look at this in greater detail on the handout later if you're more interested, that we were able to determine where they were screened in the first trimester, 2 trimesters, if they weren't screened in the first 2 trimesters, if they were screened in the 3rd trimesters, or if they were not screened at all for each of our pregnant women in 2013 and 2014. And you can see most of our cases fell into 2 groups. I hope you can see my mouse, but they were either not rescreened or they were never screened, which was, again, we talked about that in the cause with the slides on the baby bottle. Now, as we look on the second slide here in 2018 and 2019, we see that actually in terms of proportional increase, we still see a large number of cases that weren't rescreened, 36, but it was only a 63% or 64% increase when we had a over 200% increase in our total population of congenital syphilis. And again, even though we had 76 cases that had no prenatal care or never screened before delivery, that was only a 162% increase compared to the 200% increase that we had that was observed. What we do have is interesting is we have the 3 boxes in yellow. We have an increase in the boxes of women who tested positive in the first 2 trimesters, which should be a great opportunity for prevention. And we also have the boxes in the yellow where women were screened negative, were tested in the 3rd trimester, who tested negative at the 3rd trimester and tested positive at delivery, which means that they actually had late identified infections and are very hard to prevent in terms of having healthcare screenings and opportunities, because these are infections identified after traditional 3rd trimester screenings. So let's break down these causes a little bit further. So when we look at those cases in those first 2 trimesters, and we looked at the causes of the primary reasons of those cases, if we looked at maternal reinfections and treatment failures, one of the big changes we saw was maternal reinfections or treatment failure. We had 5 cases, or 6% of our cases in 2013 or 2014, go to 27 cases, or 10% of our cases in 2018 and 2019. We didn't see much of a change, even though it went to 17 cases, of mothers who were treated and the infant then meeting the case definition, which is a very unique subset of our cases where the infant still had signs and symptoms even though the mother was treated. There are a lot of reasons for this, and I'd be happy to discuss with anyone afterwards why this may occur, but it is complicated and it can have a multitude of reasons for why that may happen. And then there's a third set where the mother was not treated, and there's a lot of reasons why this may occur, and some of it is healthcare related, some of it is patient history, and some of it is a patient refusal. But we did have an increase from 1 case only in 2013 and 14 to 10 cases, and now representing 4% of our cases in 2018 and 2019. But now if we look amongst those, for those that weren't testing positive in the first 2 trimesters, and if we looked at those negative 3rd trimester screens in yellow, we went from 7 cases in 2013 and 14, which is 8% of our cases, to 43 cases, or 17% of our cases. Now, when we talk about negative 3rd trimester screens, we're talking about people who weren't identified as having a reinfection. They may have been people who were serofasting or had a prior history. So in the yellow box, we're talking about 44%, or 22 of those cases, had no prior syphilis history, which means they had never tested positive for syphilis, tested negative in the 3rd trimester, and then acquired syphilis between their 3rd trimester screen and delivery. That is an inherently difficult risk and a challenge for our syphilis prevention. But it does mean the remaining 56 had become either reinfected with latent syphilis or had observed titer fluctuations or treatment failure since their previous diagnosis after the 3rd trimester screen. Those women in that 56% were less likely to have a child with signs and symptoms of congenital syphilis. Now, I will say, as I mentioned before, we did see a decrease in the proportion of our cases that were resulting from not being rescreened in the 3rd trimester, which is excellent to know that we were having more cases, more likely to have women rescreened in the 3rd trimester, as we went from 25% of our cases to 14% of our cases, which is part of Florida rule to be rescreened at 28 to 32 weeks. And those not being rescreened are not screened at all. They went from 35% of our cases to 29% of the cases. The reason I have a mixed arrow here on the right, though, it still was a little bit of a challenge to say that it was great to have that decrease in proportion of our cases, because it still went from 29 cases to 76% of our cases had no observed prenatal care or screening for syphilis and were diagnosed at delivery. So what does this all mean for our infants? So in many ways, people will discuss whether or not the surveillance case definition is about identifying surveillance or whether or not it is about the consequences for the infant. And as of 2013, 2014, 35% of the infants had at least 1 sign or symptom of congenital syphilis, which is highlighted in the blue bar at the bottom. In 2018 and 2019, 102 or 39% of our infants had signs or symptoms of congenital syphilis, which is again showing that there are real consequences for our infants, and these increases in syphilis are at least the same or more consequences for the infant going forward. Most troubling is that we had observed 5 stillbirths in 2013 or infant deaths in 2013 and 14, and that increased to 26 stillbirths or infant deaths in 2018 and 2019. Just an interesting fact here is that 26 of 31 or 84% of our stillbirths or infant deaths were to mothers staged as early latent or unknown duration syphilis. This is interesting because typically the most infectious and causative problem of stillbirths or infant death is secondary syphilis. However, we did note that 81% of our mothers had high or very high titer syphilis, which is 1 to 32 or greater titers on their non-treponasal test at diagnosis, which again is suggestive of much more infectious syphilis than they were staged at based on surveillance case definitions. And if we look at syphilitic stillbirths and infant deaths in Florida from 2013 to 2021, I will point out that the 2021 data is based on, and all this data is based on the infant date of birth/death, but the 2021 data was extracted on early January, and the data is provisional and subject to change, but it was more so to give an idea of where we are we are headed and what we are seeing. If you look, the number of stillbirths and infants' deaths do seem to be increasing year upon year, but relatively to the proportion of cases, which is the orange bar, it actually has remained fairly flat at somewhere between mostly 10 to 12% of our infections result in syphilitic stillbirths or infant deaths. So the more female syphilis cases resulting in congenital syphilis, the more syphilitic stillbirths and infant deaths we are likely to see. So to prevent syphilitic stillbirths and infant deaths, we have to do a better job of preventing female syphilis amongst pregnant women. So one of the challenges we talk about when we're screening, we talked about the screening of mothers that resulted in syphilitic stillbirths and infant deaths. One of the challenges is that most of the women that ended up resulting in syphilitic stillbirths and infant deaths, they had no screening prior to the infant having delivered, which was 72% of them. They arrived with their test at delivery of the syphilitic stillbirth or infant death, which was 72%. 8 tested positive but were not treated prior to their delivery. 6 tested negative at their initial screening, which is what we'll talk about. 5 had a prior syphilis history and tested negative at their initial screening. So there was 11 that totally tested, that had a negative test prior to their initial screening of the syphilitic stillbirth and infant death. And there were 2 that had discordant serological results at initial screening. That meant that one of their non-treponemal and treponemal tests was positive and the other one was negative. I will point out the shortest time from negative tests, when we're talking about those 11 infections that tested negative, to stillbirth or infant death, were 56 and 62 days respectively, which meant they went from their negative test to having a diagnosed stillbirth or infant death within roughly 2 months of their infection. However, the median time frame was closer to 4 months at 129 days from their infection to stillbirth, or negative test to stillbirth. So to wrap this up, we want to describe that to summarize that we are seeing an increase in pregnant women with syphilis, and they're contributed a substantial, or these women with pregnant syphilis contribute a substantial proportion to the likely increase in congenital syphilis in Florida. More infections are being identified later in pregnancy and among women with additional risk factors such as drug use during their pregnancy. And both of these groups of women that are being identified both later in pregnancy and drug use in their pregnancy are increasingly challenging to prevent congenital syphilis cases. Infants are continuing to be at equal or greater risk for severe consequences, including death and stillbirth from their maternal syphilis infections. And so the key takeaway we want to discuss from this is that this evaluation suggests that preventing congenital syphilis in Florida has 2 increasing challenges. One is in preventing females of childbearing age from acquiring recent syphilis infections, and 2, in identifying and timely treating pregnant women with syphilis to prevent a congenital syphilis infection during their pregnancy. However, the most recent analyses suggest the improvement to work upstream, which is scenario 1, preventing females from childbearing age from acquiring recent syphilis infection, would have a greater impact because it is becoming increasingly difficult to identify and timely treat pregnant women with syphilis, as they're, as I mentioned, becoming infected later and later in pregnancy and becoming more often reinfected or having treatment failure observed during their pregnancy. Again, these findings inclusion in this presentation are those of the authors and do not necessarily represent the official position of the Florida Department of Health or the CDC. And if you have any questions, I'd be happy to take them. And I would like to acknowledge all of the help and surveillance from all of the DIS, area managers, Florida Department of Health staff, and headquarters staff with all of their help with this presentation and all of their data and surveillance efforts.
Excellent presentation. Thank you so much, Jim, for that. For anyone who has questions for our speaker today, please enter them in the Q&A box on the chat function, and we will be sure to convey those now. The first question we have is, thank you for the excellent presentation. What is the current status of the CS review boards, and are these conducted at the county health department level?
So the current status of the CS review boards is that we are in the process of developing a protocol that will have a final approach or approval to have a more rigorous standard. Some of the challenges with the review boards was making sure that we had a more full response or cyclical action response from some of these findings. So when we said we had preventable actions that were identified or opportunities for improvement, how do we document this? How do we ensure that these findings are being sent to the field? How are we ensuring that the providers are getting this information? How is all this information being shared? How do we and then the other part is bringing additional partners beyond the county health department who are on these congenital syphilis review boards to outside the STD program as well, working with maternal and child health within the Department of Health, working with county health systems. There are other organizations. So we're finalizing a protocol and engaging our partners to make sure before we bring the congenital syphilis review boards back in full standing to make sure that they're functioning at a better level or a more appropriate way.
Okay, great, thank you. Our next question is also thanking you for the presentation. I was attempting to perform analyses on the risk factors using STARS data and finding that most cases seem to be missing information for this specific variable. Is this user error, or do we need do we tend to have a large amount of missing data for risk behavior? Thank you so much.
So there are two ways to do this, and it's not necessarily always missing data. Sometimes it's there and you have to go look for it. So there's two ways of doing it, and so it depends on how you look at it. There's self-reported data, and that's one of the challenges. And then there is data that's obtained in notes and documents also within STARS. And so what I used here was self-reported data, and I took it from STARS. So it's probably a slight underreporting specifically for drug use, which we're talking about here. And I did not present data on incarceration or other risks that are also there that we talk about when we talk about risks for maternal and congenital syphilis. And it is in STARS. And one of the things that it's often incomplete, especially if we're talking about other diseases that aren't syphilis, is it requires an interview. And if the interviews aren't done and if the risks aren't completed, the rate will be much more incomplete. So the more complete it is, the better. But the other way to do it is, and we've done this in some of ours, is do a manual field review of the records for a subset or of all the cases, especially if we're talking congenital syphilis. You could probably have time to do the maternal syphilis review for the notes and other information that might be there.
Okay, thank you. Another question is asking, what are some key recommendations to our OBGYN to provide early referral to our CHD clinics?
The first thing would be to make sure that you have a strong partnership is the best thing that I can say, and try to have as much open discussion. Being knowledgeable on the topic is always great. I think the biggest key is to always make sure that they're aware of the Florida Health Rule, so that they're testing both in the first trimester and also in the third trimester. That goes a long ways. And then trying to encourage them to test at delivery. I know that the rule is a little bit complicated around testing at delivery, but it should be first trimester, 28 to 32 weeks. I don't want to just keep saying third trimester, but 28 to 32 weeks and at delivery. And that if they are having any challenges with meeting, treating, or testing, that referring to the health department, you guys make a great partner. I think that's the best way to say. And one of the things, if you have data and now you have a slide set that goes along with it, because now we have some data you can put out there, and there's been other presentations, one of the challenges is screening and testing and treating in-house becomes a challenge for some of these providers, and the health department's a great partner to have. So I know that screening at LabCorp and Quest off-site for providers is a challenge for our women, especially vulnerable women at risk for syphilis. And so referring them to the health department could be a great option rather than referring them to LabCorp to go get their blood drawn away from their primary provider.
Okay, thank you for that. Our next question, I'm assuming that the syphilis rate is also increasing in the total population. Is that correct? And what interventions are in place for the syphilis prevention program?
It is increasing in the general population, and we are continuing to do our efforts to screen and do our partner services efforts. We partner very much with also our HIV partners because we often have a lot of similar risks, especially in our male population in terms of a lot of the clients, especially with our PrEP services and our persons at risk. We try to do a lot of our early interventions, probably with our chlamydia and gonorrhea patients, because in many ways they are the ones we will see potentially at risk before we see syphilis and HIV in some ways. So it's really trying to mitigate risk and talk about having appropriate sexual health practices before we get into these challenges of disease and infection later on. But when we talk about female and maternal and congenital syphilis, you know, we have two different types of rates that we're seeing, and we're seeing rates of infection increasing in syphilis in both types of different male populations. When we talk about men who have sex with men and those that have sex with women and those that have sex with men and women. So we are seeing rates of syphilis increasing in pretty much all populations, and that is really our challenge. And we're trying to do our best with different ways of navigating all different ways to increase prevention through screening, testing, and timely treatment.
Okay. All right, thank you. What is the cost savings of preventing a CS case versus treatment for an infant?
Monumental cost savings. So the test for syphilis runs a few dollars. The RPR, usually you can, I guess the charge is a little different at a hospital versus a lab versus wherever, but we're still talking a couple dollars to $100 depending on where you go and what your insurance charges. But realistically, if you have insurance or if you go to the health department, it's a few dollars for a test. And the treatment for Bicillin is very cheap at the health department as well. And depending on what it could be, depending on the sliding scale, not very expensive either. So the cost is a few $100s, let's say, for treating a whole infection for a woman pregnant with syphilis. A baby that has congenital syphilis that results in an infection is supposed to be treated for 10 days within the NICU on IV penicillin minimum. So 10 days of IV penicillin along with x-rays, lumbar punctures, and full workup, even if there is not many other signs or symptoms along with additional respiratory distress or fractures of their bones or all these other complications, is going to cost tens, if not hundreds of thousands of dollars in charges just based on being in a NICU for 10 days on IV medications. So the cost savings is monumental to prevent congenital syphilis versus treat congenital syphilis in a clinical setting.
Okay, great. I just wanted to let everyone know that the presentation today was recorded and it will be available on the department website, the Florida Health Grand Rounds website, within the next 2 weeks for those of you that are requesting to share with others. This will conclude our webinar for today. Thank you so much for your attendance. Our next seminar will be held on March 8th and will be presented by Dr. Guede and Dr. Mead from the Moffitt Cancer Center, titled Community Cares, a Multi-Level Intervention to Increase Colorectal Cancer Screening Adherence in Community Clinics. Be sure to also refer to the website for upcoming registration links and announcements. And a special thank you to our presenter today, James Mathias, for joining us and giving us this wonderful seminar. So thank you again, and to all have a wonderful day. Thank you.